Assalamualaikum and good morning everyone. We will continue our discussion with hyperosmolar hyperglycemic state, which is one of the diabetes mellitus emergency. The diagnostic criteria for HSAH is marked hyperglycemia, where the serum hyperglycemia is more than 30 millimole per liter. And second is hyperosmolarity, where the serum osmolarity is more than 320 milliosmol per kilo. The formula we use to calculate is 2 times sodium plus glucose, and urea is not used in this calculation because it can move freely across the cellular membrane and it does not induce osmotic gradient across the membrane. The third one is Hypo Hypovolemia in the absence of hypoketonemia, which is less than 3 millimole per liter, or acidosis where pH is more than 7.3 and HCO2 is more than 15 millimole per liter. When acidosis is present, causes of acidosis such as lactic acid and toxicology screen need to be investigated. In case of acute cognitive impairment present, we can suspect cerebral edema where there is significant electrolyte disturbance, hyperosmolarity, more than 330 milliosmol per kilo, sudden drop in osmolarity, severe dehydration, infection and sepsis, hypoglycemia during treatment, and also renal failure. The pathophysiology is very much similar to the DKA, but the reason why there is lack of severe ketoacidosis is that insulin is present, but insulin is low, but it is sufficient to prevent lipolysis and subsequent ketogenesis. And the physiologic stress results in an inflammatory state with elevated counter-regulatory hormones such as glucagon, catecholamine, cortisol, and growth hormone. This hormone will cause increased gluconeogenesis and glycogenolysis, breakdown of fat into free fatty acid that will cause metabolic acidosis and also proteolysis. The resulting osmotic diuresis causes hypovolemia and electrolyte losses. For the clinical features, patient will present with weakness, dyspnea, chest or abdominal pain, or mental status changes and has pre-existing lung, heart, renal or neurologic disease. Dehydration can be deceptive and may not be reflective of the seriousness of the fluid depletion because the hypertonicity leads to preservation of intravascular volume. For the precipitating factors, we have infection and sepsis, stroke, intracranial hemorrhage, MI, pulmonary embolism, and also poor treatment adherence. For the management goal, the goal of treatment of HS are to treat the underlying cause as well as to gradually and safely normalize the osmolarity, replace fluid and electrolyte losses, normalize blood glucose, and prevention of complication. For the management, the first one is fluid resuscitation. The initial fluid therapy is used to expand intravascular volume, improve tissue perfusion, securing adequate urine, and also to reduce serum glucose. 0.9% saline solution is the principal fluid to restore circulating volume and reverse dehydration. And we can change to half saline solution if the And we can change to half saline solution if the osmolarity is not declining despite positive fluid balance. Second is insulin. We can start insulin infusion after fluid resuscitation has begun to avoid circulatory collapse from shift of extracellular fluid into intracellular space. And we can start with low-dose insulin, which is 0.05 unit per kg per hour, because patient more sensitive to insulin compared to DKA patient. And we aim for fall in blood glucose 3 to 4 millimole per liter, and then we can do the ST monitoring hourly. When the patient is alert, able to tolerate orally, we can initiate subcut insulin. Next is potassium. If potassium is less than 3.5, we can give potassium supplement 40 millimole per hour, that is 3 gram kcal per hour. Not more than this because it can induce cardiac arrest. If serum potassium is more than 5, we can will not give potassium but check potassium 2 hourly. And if serum potassium more than 3 but less than 5, we can give 20 to 30 millimole per liter potassium in each liter of IV fluid to maintain serum potassium at 4 to 5 millimole per liter. The resolution of HSAH is when the patient is alert, well, and serum osmolality is less than 320 milliosmol per kilo, and also plasma glucose level is less than 14 millimole per kilo. That is the end of my slide. I guess that's all from Doctor.
So, Eisyah, apa yang lebih penting dalam HSAH? Insulin ke fluid?
Insulin.
Insulin? Sebab apa?
Ya. Sebab patient ada sensitivity dekat insulin, sebab tu dia jadi acidotic, Doktor.
Betul ke HSAH mana ada acidotic sayang? Bukan present ke? Dia tak ada ketosis kan?
Betul.
So basically beza DTA dengan HSAH ni, tadi saya cakap DTA ni basically dia dalam type 1 DM kan, patient memang tak ada issue. So dia akan ada slight breakdown of dia punya fatty acid jadi ketomodis. Kalau dalam HSAH ni dia ada lagi macam low insulin level, tapi still ada cukup untuk maintain dia tak jadi ketosis lah. Basically insulin is not very very important pada nombor 1 lah dalam HSAH. Dia fluid yang paling penting sebab HSAH ni patient memang really sangat dehydrated lah because of the high sugar kan. Sugar dia punya level kita tak rasa apa-apa 30 kan. Cukup betul. Betul tak 30 Eisyah awak kan?
Betul tu.
30 kan. So insulin dia akan menyebabkan patient akan lost water lagi banyak lah. Okay. So dan memang mortality in HSAH is 3 times higher than DTA lah. So yang paling penting kita kena bagi fluid dulu dekat dia. Okay. Sebab dia ada low level of insulin lah. Still boleh avoid ketosis lagi lah. So kena bagi fluid dulu. Jadi tak payah start insulin. Cuma kalau insulin tu lambat ke apa tu, maksudnya kita punya yang first kali kita kena aim untuk rehydrate the patient lah. Okay. Lagi Dr. Fahri ada nama
Doktor ada soalan. Kenapa dalam patient HSAH kita kena bagi prophylactic low molecular weight heparin?
Ada dalam CTG kan ni kan?
Ya Doktor, tapi dia pun tak explain.
Yang ni saya pun tak ada jawapan. Jadi tak pasti. Nanti saya beritahu.
Okay.
Doktor Fahri ada ni. Nanti saya beritahu. Saya pun tak sure sebab apa. Kalau ni patient DTA Actually patient boleh, kalau boleh take orally, boleh je ambil. Tapi usually kita NDM tu dalam patient yang tak conscious kan. Maksudnya patient yang delirious lah. Kita nampak dia very tachypneic. And then kalau kita tanya pun GCS dia tak full. Just takut nanti kita kena terpaksa intubate dia lah. Usually macam tu lah. Tak ada kata, ada guideline kata kena NDM, saya tak pernah dengar lah. Tapi actually boleh allow orally. Kalau patient yang mild DKA yang okay, dia punya conscious level okay, dia tak rasa dia akan expirate, jadi boleh saya ambil orally. Tapi diabetes diet lah, jangan minta gula pula kat dia. Okay, ada soalan lagi tak? Okay, kalau tak ada, kita end our CME. Saya nak ucap terima kasih lah kepada Eisyah dan juga Farhana untuk presentation ni. Bagus sebab ambil daripada CPG lah. Ini memang yang kita biasa pakai lah dekat Malaysia kan. So kita ada di sini je lah. Okay, terima kasih atas.
Terima kasih, Doktor.
Terima kasih, Doktor.